Honestly, no. I would say 10 to 15% of the time, they'll come back and say, I don't have enough cells, and then they'll want me to re-aspirate it. Okay, so that's a good question. And, that's it's not an uncommon question. It's like a 25 gauge needle. Really? That sucker's pretty small. No, it does a nice job. So we're happy with that. But, as you said, those 10 to 15% of the time, I usually will then choose a 22 gauge needle. Because if I didn't get enough last time, we might as well try and do it that way. I would say probably less than 10%. And some of that ends up being, going back to the very beginning, which animals will go ahead and cull out in the first place. So we realize that some of them don't have a coagulopathy, or that do have a coagulopathy, or their blood work's black and they have very low platelets, and we realize that we don't want to stick them now. Some of those animals, our strategy is let's get the coagulopathy under control, realize I do have lesions, and if I can get that under control, then I'll come back at a later time and try and do the sampling then, just because it's safer then. Solid lesions, probably not going to have a problem. One challenge that I would think about that wasn't on my original slide is if I have a cat that has what I would suspect is hepatic lipidosis, those livers tend to be a little bit more friable and more prone to bleeding. So I will talk to the clinician about that. And then it becomes, how important is it to know that it's truly hepatic lipidosis? One nice thing about hepatic lipidosis, you usually have a really bright hyperechoic liver. It does what we call absorb the sound waves, so that, as you go deeper and deeper, you just can't get enough sound waves deep into the liver, and then I don't see the portal vein markings and those sorts of things. So I've got a lot of information before an aspirate to say, look, this cat has hepatic lipidosis. And so we often will not sample them and move on. Now, a big cavitated lesion, that doesn't, if it's a spleen, we might not. And one of the reasons we wouldn't with a spleen is if it turns out to be a hemangiosarcoma, turns out to be a hematoma, a hemangioma, all the H-omas in a spleen, it's still going to take it out. So we don't sample it. We just realize we need to take it out. Cavitated lesion somewhere else, I'll actually probably sample the fluid by itself, and then try and find somewhere on the edge where there's less of that to try and sample that area if I can. So it's kind of a dual purpose in that respect. Now, one of the challenges with bowel is it's not really fixed in place very well. And so sometimes I'll get my needle right up against it, and as you try and stick the needle into it, then the bowel starts swimming away from you. And so that gets to be very frustrating. Sometimes we say, well, can somebody just hold it? No, they don't want to do that. So what I actually do is I will get the needle right up against it, and then what I find I have to do is a very sharp, quick thrust instead of a slow, deliberate one, and that just punctures into it a little bit better. And then once I've gotten the needle into it, to me it's analogous to having a toothpick and an olive in your favorite beverage of choice that uses olives, and now you need to attach something to use the suction method. Frequently, we're going to get multiple nodules in organs. Liver is a common one to have multiple. One of our assumptions becomes that all the nodules are the same thing. Okay, I don't know if that's true or not. Most of the time, I hope it's true, because we don't sample them all, and so that's a slightly different story. So how do I choose which one to sample? It goes back to which one's going to be closest. And I do prefer to use the left liver. And the reason I prefer the left liver is because the gallbladder lives in the right. And so I would like to stay as far away from the gallbladder as possible. If it's only in the right, of course, I'll do that. So I will pick one that's the most shallow and go from there. If I can see a lesion, I'll go ahead and stick a needle in it. And so if I'm ultrasounding the lung and I see a lesion, I know it's right up against the body wall, and then the chance of introducing air into the pleural space becomes much less. When I was a resident in North Carolina State, one of the oncologists I worked with talked to me about lung lesions. And he said, Todd, how do I treat this lung disease if I don't know what it is? I'm like, I don't know. How do I treat a pneumothorax? He goes, you stick a tube in. He goes, I know how to treat a pneumothorax, no problem. So if you give him a pneumothorax, I can handle that. But I need to know what it is. So that was his approach to lung lesions and letting us stick needles into them. So I will do that sonographically. Obviously, if I can't see it sonographically, if it's just deep to the body wall surrounded by gas, I need a different way. We will take those animals to CT and biopsy their lung or find needle aspirate of their lung in CT. Most of the time, we do introduce a little bit of gas. And most of the time that gas is something we don't need to do any intervention on. We do watch those animals throughout the day in case they would, but usually, yes, they get a little bit of a pneumothorax, but it's enough they compensate and then they reseal and go ahead and eliminate that air.